His training. So now I would like to invite our speaker, Dr. Koo, to the stage for his presentation. Yeah. Please welcome him.
Good morning, guys. My name is Dr. Koo. I'm from Malaysia, and I'm honored to have everyone here today to have me share what I've done in dental implants, and hopefully you guys can take away from this with some new ideas, and hopefully after this you guys can give me more ideas as well. I'm sure most of you have done a lot of dental implants. Some of you have just started placing dental implants. And so we're gonna go from the basic outline of what dental implants are in terms of, I'm not gonna give you a history of dental implants. I don't think we need to know that. That's not really practical at this point. Dental implants have been around, I'd say, since Brennemark, since the early 80s. And a lot of the ideas have been carried down from Brennemark. And that includes the All-in-4, the All-in-X, the zygomatics. All of this are the birth child of Brennemark. And I'm from Tooth Hab Dental Center. If you guys are interested to come over to Malaysia, we'll set up a good day for you to come, and you can observe how we do work there, how we do some of the full arch surgeries. We're doing about 2 or 3, sometimes 5 a month, from basic full arch to more complex full arches that require zygomatics or some other extramaxillary techniques that have helped me achieve immediate loading or immediate bridges for the patients. Just a show of hands, how many people are new to dental implants? So I can. Oh. So just a show of hands, how many of you are new to dental implants? Not all of you have placed more than 20, 30 dental implants? Yeah? Cool. And how many of you have done full arch? All right, cool. There you go, back there as well. So the gist of today is we're gonna go look at okay, it's working. So we're gonna have a brief outlook at how do we diagnose patients when they walk into the door. They walk in the door and they come in with dental problems. But then again, we have to see them as a whole human. They're coming into you with a bunch of problems that you're worried about. And we're gonna look at the medical history of the patient. We're gonna see, do they have any chronic illnesses? Do they have any acute problems that they're dealing with? Could be because of the dental condition, like buccal space abscess, canine abscess. They could be having issues that are either acute or chronic. And we'd have to address that before we even think about putting implants in them. And then look at a dental history. The term terminal dentition is often vague because your terms of what's terminal is different from what I think is terminal. And especially if there are prosthodontists here today, or like an orthodontist, their version of terminal is different from mine as well. And your version stays the same as yours. Just take what you can take today, and if you think like, oh my God, that's too aggressive, he's removing too many teeth, that's okay. That's on your decision, and we'll actually, hopefully, get a meeting point of what's best for the patient in the end of the day. And then we look at social history. You'll see a bunch of patients, they come in with smoking or just poor oral hygiene. Now, poor oral hygiene is a thing because if your patient's already having bad hygiene, and then all of your teeth are in severe periodontal conditions, badly broken down, oral hygiene is atrocious, and then you think, okay, I'm gonna take all the teeth out, give you a fresh start, but the patient's hygiene doesn't change. Their dietary, their diet is just made up of like sugar, refined carbohydrates, and that is the issue that you need to address before even taking the teeth out and telling the patients and taking the money from them or having them go through the entire cycle of the treatment that you plan to do for them. That's why social history is important. And also, you'd want to know what they're doing. For example, are they voice singers? Do they play the saxophone? A lot of the treatments that you do actually alter the speech of the patient for better or for worse. And if they're used to the past, anything new is going to be different, and anything new is going to be very difficult for them to accept. And then we talk about an intraoral exam. Everybody knows the intraoral exam. You go through it, you look into their mouth, you look, hey, is there caries? Is there badly broken down teeth? Is there an abscess? The other part that you need to realize is how broken down are their teeth to a point where do you actually know what their bite is? Do you actually know what you're comfortable in? If they're in, for example, a deep bite, or they're in sort of a class 3 over the years, not even born with, not developmental. It's just over the years they've already gone into a class 3 because of bad dental attrition or the loss of anterior teeth, and they just got their mandible forward, and you try to alter that. That's going to be difficult unless you're a surgeon and you're going to do orthodontic surgery. That trying to get them back into normal bite is going to be a tough battle because you can do it, but is the patient going to be happy with it? And that's why the intraoral exam really gives an outline of how you actually want to go about seeing your patients. Extraoral exam. Extraoral exams, you're looking at the guy, you're looking at his face. Now, if a guy walks through the door here, I don't need a LEDCEF. I don't need a LEDCEF. I don't need to do an x-ray. I don't need to do cephalometrics. I can tell just by the face, is he more a class 3 or is he more a class 2? Does he have a weak mandible? Does he have a long face? Does he have a long mandible? So in the end of the day, it's like, if the guy comes in and they don't look as a class 1, just by the facial structure, you should watch out for like how to treat these patients. X-rays, you're gonna see the bone quality, bone density, and also from there, figure out prosthetic space. Now you can have really good bone and no prosthetic space. Or you can have a lot of bone, but really poor bone. So that's something that you really need to consider. Sometimes you get implants in there. You can get many implants in there. But is it prosthetically easy for the patient to get a bridge? Are there implants in a position where they can clean them? Or you can restore them? And that's why less is more in some cases. All on 4 makes sense because it's easy to clean. And again, I'm going back to Malo when he first came up with the all on 4. It's easy to clean. There's enough space for the prostheses. And also, it's easy to fix your restorations. Okay. So when you're looking at the patients again, there's some absolute contraindications when you're treating the patient in general dental clinic and you're not treating them in a hospital. One of the main contraindications is your patient's on bisphosphonates. Are they on like Forcimax? Or are they on something for bone remodeling because of like osteoporosis? For me, I choose not to do those patients at all. There are some like protocols where you can follow to help patients with bisphosphonates to get dental implants. But if you're just starting off and you're seeing these patients in your dental clinic and you don't want to deal with the complications of like medical related osteonecrosis of the jaw, you don't want to deal with stuff like that. We do have a separate lecture if we have time today about MRO-NJ, if we have time. Second is post-radiotherapy, head and neck area. Again, the vascularity of the area is difficult. There are some measures where we can go about taking the implants into areas with more vascularity or away from the radiation site. We're looking at the zygomatic area or the base of the mandible, or even thinking about making fibula implants with the microvascular surgery. Again, these are not things that I do, and these are not things that if you're gonna start off in dental implants or if you're gonna have a running practice doing a lot of full arch, these are things that you don't really wanna touch as well. Another thing is low vitamin D levels. You come in, you see a patient, bone looks good, everything looks good. There's no real periodontitis, but he somehow gets a lot of destruction of his teeth, and then you put an implant in there, everything goes well, beautiful, all fail, everything fails. And then you take, hey, buddy, go to the doctor, get your vitamin D levels, and he's below. He's really low in vitamin D. And you start thinking, what was the cause? And you think there's like a cluster effect from you placing too many implants or him rejecting titanium or whatever. It's not really that. It's more, the vitamin D actually is in the cycle of calcium and how you integrate and remodel your bone. So vitamin D levels are very important, especially if you're looking at females who don't go under the sun a lot, even men, especially in our Asian culture, we don't like to go under the sun too much. Get the vitamin D levels checked for your patients, supplement them that, see the levels, get the levels stabilized, then proceed with the patient. HbA1c, another thing is, I do diabetic patients as well. I do diabetic patients with very bad HbA1cs. But if you're gonna start out and you wanna practice without complications, check that level, make sure it's below 8, even below 7.5. Try to be a bit strict with that if you wanna have a practice that's very predictable in your results. Again, patients are warfarin, they've just done a stent or whatever, and warfarin, the INR shouldn't be more than 3.5. Some surgeons are okay with 4, but again, these are things you should really avoid when you're in your dental chair, in your dental clinic. And it's time to do those cases in the hospital or have your medical doctor actually have a good communication with you and see where you go from there. Again, dental history. Poor oral hygiene is paramount. Now, poor oral hygiene is not just how you brush your teeth. A lot of us think it's, hey, we brush our teeth 3 times a day. We're fine. Poor oral hygiene is like sleep hygiene. How do you sleep at night? What time do you go to bed? Are you consuming caffeine before you go to bed? Poor oral hygiene comes from your diet. Poor oral hygiene comes from your habits with the way you chew, with the way you breathe, with the way you bite. So poor oral hygiene, you see patients coming, hey, I brush my teeth 3 times a day. And you see notches on the side, you see teeth that are like having a lot of black triangles. These are patients that have poor oral hygiene, not because they don't brush their teeth, because they brush their teeth wrong, or because they're having a high carbohydrate diet and they're not having any control over constant food consumption in between the sessions where they're supposed to brush their teeth. These are things that need to be addressed. Once poor oral hygiene is fixed, a lot of your problems disappear. And that's important for you before you do dental implants. Aggressive periodontitis. This is where, how many of you have seen all-on-4 cases and you see extractions immediately, everything, and then implants placed immediately? I do those as well. What's very important when you're dealing with aggressive periodontitis is you have to clean everything. Not just the socket. You have to take away the alveolar bone. Take it all away. And that people look at it like, oh, you do such aggressive bone reductions. I'm taking away bone that's going to resorb. We know biologically that alveolar bone resorbs. So all the research out there on all on 4, all on X, they're all after bone reduction. The original Malo papers were done on all on 4s and all on X's that have lasted 25, 30 years. And a lot of his data is from cases with aggressive bone reduction. Because back in the day, he only used acrylic for his bridges, pure acrylic, not even a titanium bar. And he needed 15 millimeters of height for the acrylic to last long. So he mowed down all the bone, aggressive bone reduction for that prosthetic space. Now at the same time, it helped so much with the longevity of the implants because now they're at the base of your skull. They're at the base of your mandible. Those are areas that don't really resorb. Sure enough, when you do your reductions, your implant torque goes down because you don't have the cortical bone on the surface or the crest anymore. And that's when bicortical anchorage to the nasal area or buccolingual to the mandible helps so much when immediate loading is at stake. Parafunctional habits. If you see a patient that comes in and they have a really big masseter, or you have a sleep apnea at night, which also contributes to the grinding of the teeth, you need to address that before you can give a restoration. Everything will just come to bridges cracking, screw loosening, implants integrated, but your prosthesis just keeps having problems because they're by your parafunctional habits at night, or even their lip support. Then the compliance of the patient comes down because they're not comfortable with the prostheses because the lip can't close, even though everything looks textbook beautiful. Combination syndrome, you see a lot of this in cases when they're having dentures for a long period of time. The maxillary tuberosity comes down and you have no space for your prosthetics. These are some things that we need to address as well. And sometimes that means crushing the sinus and lifting everything upwards, or opening up the bite. Again, these are things that you need to be aware of when you're looking at your patients. Multiple ill-fitting restorations. You might have really good teeth, but they have a lot of large restorations, either amalgam, composite, root canals, crowns, and they're all doing good. They're in bite, they're doing good. But for you to restore them back while restoring the areas that are edentulous, it's difficult, number one. Number two, it's not gonna last long because you're taking away more teeth, substance of teeth, and you try to build from there. So again, multiple ill-fitting restorations, we call it terminal. Aesthetic, functional, and compliance. Why do we have teeth? We have teeth to look good. We have teeth to eat. So I come from a society that has a lot of Asians. So we have Chinese, we have the Malays, we have the Indians. And a lot of the times they ask me, hey, can I keep my teeth? It's still good. There's no caries. There's no mobility. There's no pain. Can I keep it? I tell them you can't even chew with it. That's the whole point of having teeth, is to chew with it and to look good. So again, it's the shift of what we learn in dental school is the teeth are to be preserved. We're moving more towards now, the teeth are for you to eat good and look good. So even if you can eat good, but they don't look good, a lot of people, especially my Western patients, they're not happy with that. Again, here we bring to more of a case scenario. Dental implants were done on the lower Q3, third quadrant, about 6-7 years ago. And then he comes over now, and he has a root canal that's fractured, that's somehow linked to a bridge. Again, this is poor dental work. And you'd see a lot of cases. This lasted probably like 6 months. So again, I told him, you should have met your dentist. Because when you met your dentist, now you have to do more work. If he came in and he didn't meet this dentist, he wouldn't have 3 crowns linked together as a bridge. I mean, back in the olden days, especially in Malaysia, this was the bridge that were thought in the University of Malaysia to splint bridges together on teeth, even though there's no real pontic. And that actually causes more problems because everything fractures and root canals fail over them because there will be a marginal leakage from the marginal area into the bridge, and then it just fractures. You can see the tooth here has adequate interradicular bone. And at the same time, there's a big fracture underneath the crown here. And everything's linked. So when we chop the crown away, we'd have to see the integrity of the other teeth as well. Here, the implants have been placed immediately after extraction. So how many of you do immediate implants? That's a lot. And when you do immediate implants, do you find it difficult to aim directly at the radicular area? Right? So the main thing that you need to understand is like, how do you aim at the radicular area when your drill bit slips? What we do is actually we cut the crown off. We start drilling through the roots. And we prepare the implant bit before we put the implant in, while the roots are still there. Then we take the roots out, and then we put the implant in. Now you can't do that for every case. For example, if your case comes in and there's no interradicular bone, or the interradicular bone is very shallow and there's a really, really thick root connection here, you can actually aim that implant mesially and tilt it distally for the emergence to come in the middle. So again, there are many ways to skin the cat. How do you skin this cat? In the end of the day, what you want to give the patient is function and aesthetics. Here we put the MEGAGEN implant in there, and we put an anatomical healing abutment. Now, the good thing about MEGAGEN, and it comes with the blue diamond, comes with the anti-ridge, comes with the custom metal healing abutments that come in sizes that are separate. So if you get the metal healing abutment, you have an extraction socket there. That metal healing abutment actually serves as like a custom healing abutment that closes off the socket from the other areas. Now, do we graft this area? I don't think we need to graft this area. There's no need for grafting. Whenever you're introducing foreign materials into a human, there's going to be reactions to it. So whenever I can, I try not to graft at all. I try to stay graftless whenever I can, unless I'm building up something that isn't there anymore. I'm building up something that doesn't exist, and there's no chance for it to exist anymore. Here we got the crown in. Again, it's not ideal because we can't really shave or restructure everything around here from the previous crowns that were linked. We don't want to destroy the other teeth while we shave it off. So again, anytime people get bridges done, which is a very old-fashioned way of doing dentistry, you're gonna have real problems dealing with the leftover crowns there, especially with the PFMs. Now if I open it up, it can come together with the crown. And then it's more money for me, I gotta put more implants, but again, that's not what the patient wants. Biological width. Now, how many of you understand in general how biological width plays in your implant placement? Now, a lot of the lectures, they confuse me because this is actually an implant and it uses a tissue level implant as an example of this. So you can see that the junctional epithelium and the connective tissue adds up to the biological width, okay? So imagine right now, this is your bone level implant. Your abutments must be at tissue level, either as a multi-unit abutment or a custom abutment. If your abutment here is too short, for example, before your crown, you will have inadequate biological width. And what happens to the human body when we have inadequate biological width? We make it ourselves. How do we do that? The body resorbs the marginal bone to create biological width, right? So I can show you an example of a case. Again, biological width of a tooth is a different idea from a biological width from an implant. Here is an ideal emergence for your crown. It's very important for your crowns to have an ideal emergence. These are separate cases, two different cases. But you can see here, the implant emerges out, and this custom abutment acts as a tissue level, just like the first picture you saw, right? Same thing here. There's a tissue level surface to it with proper emergence. And that's how in 5 to 6 years you don't see any bone loss. Here, biological width is violated. Look at this. This tissue level is not high enough for tissues to attach here. And initially, when the tissue wasn't enough, the implants have to be placed deeper. Now you can open your gums up, put the implant crestally, and still see this marginal loss or these problems. And this is a really nice case because it shows you that when your implant crown emerges too perpendicular to the crest, there will be food lodgement that causes bone loss. That's number one. Number two, the implant was placed too shallow, so there's no biological width around the gingiva. So how do you circumvent cases like this? Again, we go back to here. We go back to here. Like I said, if you put the implant in there and there's not enough tissue, your body's gonna make the tissue yourself. It's gonna cause resorption. So when you don't have enough tissue, what do? You need to put that implant deeper. You put that implant deeper because there's not enough tissue. So when there's not enough tissue, your body makes biological width itself. So we put the implant, for example, here, if this is not more than 2 mm. You want to go 2 mm deeper. Then you get your biological width. And that's why you don't let your lab, don't let Charlie pick your stock abutment. You pick it. You measure it, chair side. How do you pick your abutments? You measure it chair side. Or you measure it chair side, and then you send it to Charlie and tell him, make a custom abutment. Make it custom. Make it have proper emergence away from the implant, not perpendicular. You don't want your lab to come in with a crown like this. Again, here, same problem actually, but then again, there's enough tissue here. So the mistake that my associate did, this wasn't done by me, this was done by my associate. The mistake he did is forgivable here because number one, there's more tissue. Number two, the crown is not big enough for food to go under. So the mistake on the left cannot be forgiven on the right because the crown is bigger, the space is bigger, the food gets lodged underneath. Number one. Number two, the tissue is thinner. The tissue is thinner and there's more space. So there's more space and tissue is thinner, so you would need more depth to create biological width. Again, initial stability. How do you measure initial stability? Most of you guys. Do you just take a torque wrench? Or do you guys, any of you use Austell? Do you use Austell? Okay. And what is the protocol for you to put a cover screw, a healing abutment? In the olden days, anything below 20, we put a cover screw. And then above 20, we put a healing abutment. And then above 35, we think of immediate loading or immediate temporization. I follow 35 to 60, I load it. 15, 20, I can put a healing abutment in, provided there's no mobility of the implant. Even your torque is high, if you're going from an from an angle, if the thing's moving, that's not real stability. So you have to check the mobility of your implant, not just the torque. The Austell is actually just a vibration. And it doesn't really give you an idea. I mean, it gives you an idea, but you don't really need it. You don't really need a number to tell you an idea whether your implant's mobile or not. And the torque tells you circumferentially how tight your implant is. The Austell tells you is there mobility towards the sites that have not enough bone. So I can check that with a probe. I don't need an Austell. Unless you're writing a research paper, you can use the Austell. But other than that, I don't use it. When you put implants in, there's a saying, how many of you do immediate bridges for your patients after all-on-4? Like the same day or the day after, right? The day after, right? So day after is fine, 3 days is fine. But if you're going to like 4 weeks, 3 weeks, there's a stability dip. There's a stability dip, and then you'll be surprised. You're like, oh man, some of these abutments are. When I torque in my abutments, it becomes worse. Especially how many of you put multi-units the same day of the surgery? Or how many of you uncover it later and put the multi-units? Same day, right? One abutment at one time, right? That should be the way. Because if you uncover it later, that means in transition, your patient's wearing a denture. And that denture actually is worse for your implants than a bridge because there's constant mobility and banging onto the implants. So you rather splint them together to do a cross-arch stabilization for your immediate loading. Now for those who understand there's a stability dip, so let's just say you started off at about 60 and then it comes down and then it becomes secondary here. There's a dip, and this dip comes in about 3 to 4 weeks. 3 to 4 weeks. So if you're not loading your case the same week or the day after, just load it 3 months later. Not good to load it in like 3 weeks, 4 weeks. That's at the stability dip. Austell. So the ISQ is a resonance frequency analysis. You attach a peg on top of your implant, and then the magnet sees how much vibration it's happening, and then gives you a number. And that number that you get, if you above 85, or 70, you load it. If it's 60, if it's splinted, then you load it. To me, that's not necessary because you don't need a vibration of the something on top of your implant to tell you whether your implants are solid or not. What you need is actually understanding the torque of your implant, understanding where your implants are anchored. Is the torque only from the crestal? If the torque's only from the crestal, you can have high torque on 2 mm of crestal maxillary bone too. And then you load it and it fails. Even your ostel tells you high value. And then you load it and it fails because all the stability is from your crestal bone. And your crestal bone is the first to remodel. So again, loading, always try bicortical anchorage, always long implants, always traditional all-in-X. For me. Densa. Anyone uses Densa burrs? Yeah. I don't use them. To me, it's a gimmick. I think the Densa burrs are a gimmick because the risk of using them is just so much higher than not using them. When you're using Densa burrs, you are reversing and compacting bone to the base. Now, if we learn anything from bone biology, densifying bone has to be done in a very, very strict protocol. There's got to be very good irrigation. That bone's got to be D4, and I would want it D5 for you to do it. Now again, any kind of implant that's manufactured by you through gadgets to gain more stability, it's not going to be really stable. If you have a D4, bone, all right, and you're densifying everything here, and then all the leftover tissues of the bone gets collected on the side, and then you say, hey, I have a very high torque. It's the same idea of you putting your implant in graft material, if you think about it, and then you get a high torque. But that's not really in native bone. You're not in the patient's vascular bone. You're densifying and you're putting your implant back into bone that has been removed. That's similar to you putting your implant in graft material that you just placed. You get a high torque, but it's not native bone, there's no vascularity. So I try to avoid using densifying burrs because they mask the condition of the bone. If I had low stability here and I'm doing a full arch, I corticate linguobuccally. I know that my apex is in cortical bone and I'm in cortical bone here. I'd rather do that. I know it's real bone. Or, in some cases, we densify class 2, class 3s, and we cause more necrosis. Because we're drilling bone. You've seen a lot of bone necrosis before. Have you ever drilled when the irrigation doesn't reach the apex and you see the bone burning at the end of it? That's you necrosing the bone. So the tip for, I don't know if you got it, because I got this recently. Nobody taught me this. The tip is, when you drill, it goes like CPR. Staying alive, staying alive. Ha, 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 ha. Then you're out. Because you want to irrigate the bone while you're drilling. You don't want to go even there's water on the top, there's no water at the base. So you want to go out, out. You want it to be cool. You want the drip, and then you see in maxillofacial surgeries, you're always directing the irrigation at the burr, the tip of the burr. The problem with implants is, unlike maxillary screws where you're doing IMFs or whatever, that tip of the burr is 10 to 16 mm below the crest. You're not really going to be able to irrigate it with one drill. So here is an example of a case we did on the anterior area with what we call an RE implant. So an RE implant has a long cuff on the head of it. And I think, do you have any RE or BD cuffs?
Maybe BD cuffs.
Yeah, it's the same as the BD cuff. It's just the fixture is different. The BD cuff, the fixture is a blue diamond. The RE, the fixture on the bottom is the any ridge. But the design of it is exactly the same. So again, here you can see there's a cuff on the buccal section. And that cuff stays there. And it's smooth surface. So again, here we realize this, you do not need bone grafts in cases with less bone, or there's a cleft there. Just insert a smooth surface there, and then acts as if your implant was deeper and there's an abutment coming out. And that lets your soft tissue stay stable over there, lets you avoid bone grafts that causes more problems later, because bone grafts causes more swelling, and your patients should actually react different to bone grafts. Every patient reacts different to bone grafts. And your tissue, it becomes unpredictable when you do bone grafts. Is it gonna shrink? Is it gonna swell? Is it gonna have particulates flying out? Try to avoid the graft. So in the new trend, the BD cuffs are there to avoid grafting of the crestal area and trying to get apical primary stability with this. And here you can see how the BD cuff is inserted. You see the threads. And we insert, you see how there's no bone there, there's a cleft. But it's okay. You can insert it until the threads disappear. And again, I put it a little deeper for the emergence of your crown. But the idea is there's no graft needed here. And that's amazing because now all the Korean implant brands have made a version of this, a long tissue level. This implant was 16 millimeters, but only 8 mm were threaded. Everything else was just a long cuff on the height. And we unscrew the top because it's delivered as an external hex on the top. You can see the cuff exposed. See the tissue on tooth number 21. And that's the crown. No graft needed. And I hope that Charlie can show you guys some BD cuffs later. Yeah. No cuffs needed. Now, a case like this, I was referred this patient by one of my buddies, and he told me the guy just wants to do one tooth. If I had teeth like this, I'd take all of them out. I would do all on X on myself. Because I want to look good. Again, you need to understand where's the zenith when you're putting implants. If you put an implant out of the zenith, here, when you restore, well, let's say you put an implant here, out of the zenith. When you restore your implant, your emergence becomes a bulk here. And your implant doesn't come out with proper aesthetics. So we need to know where the zenith is, especially with FP1s. Do you know what's FP1, 2, 3? So with FP1s, we need to know where the zenith is. So with full arch, I don't do FP1s. I just don't want to do it. It's just too much work. I don't think it will last long. It's just, yeah, FP3. FP3, yeah. We need to maintain some amount of like tissue for your marginal and your interdental papilla, and then we need the implant to be about 3 to 4 mm below the zenith for you to get proper emergence. Otherwise, you're gonna start seeing the gray area there, and it's gonna be difficult for your patients. But then again, if the patients are okay with it, they have a low smile line, you care, they don't care. Here, again, here's the RE implant with the immediate crown that we made, loaded. And you can see it's an external hex crown. So we just load it in externally. And you can see the height of the non-threaded portion. And that's why we don't need a bone graft for this. We just need proper apical anchorage. In fact, this, I do it to the nasal floor. So once I get apical anchorage to the nasal floor, I know this implant can be loaded. And I know this implant, within 6 weeks, I go to finals. My colleagues in Brazil, within a day, they go to finals. My colleagues in India too, within a day, he goes to the finals. So, again, you can do it, but prosthetically, is it going to be predictable? Like, I mean, the implant stays there, it's not going to fail, but prosthetically, can you predict the soft tissue? Can you predict how much emerges? I don't know how you do it, right? All right. So this guy came, and he's 50 years in dentures. Now we're moving to full arch. I think basic dental implants, we moved from like the first initial idea, and then we moved into some of the new ideas of the BD cuffs for single dental implants. And I'm not going to talk about grafts unless we have time later. Sinus lifts, GBRs, okay? And this guy comes in, 50 years in dentures. Look at the lower teeth. Look at this, combination syndrome. Do you call this terminal? If you see a case like this, will you extract everything? No. There's no mobility. There's no caries. I extracted everything. Now, I'm not saying you should, okay? But I extract everything. Because, again, the combination syndrome here, the maxillary area has gone to the mandible area with bone. And then the lower incisors are all attrited and super erupted with bone to smash it to the maxilla. So to me, this is a non-restorable teeth. It's non-restorable, it looks crappy, in fact, it looks like shit. So like, I don't see the point of keeping the teeth. I told the patient, you either wear dentures, but if you want to get proper dental implants and you want to look good and eat well, we need to take everything away. And it's a conversation you have with your patients. Do you want to look good? Again, we go back to why do we have teeth? It's function, aesthetics, and compliance. So again, what are the priorities of All-MX? Immediate or early loading. Early in this case, we're talking about within a week. Reduction of post-surgical complications. How do we reduce that? No bone grafts. Surgical complications from bone grafts are so hard to predict, especially if you see a case where bilateral sinus lifts are needed. You do the sinus lifts, you do a perfect job. 6 months later, you want to put your implants in, and it fails. That's lucky, because you fail at 6 months, and you know you got to move forward. The other scenario is bilateral sinus lifts. Put the implants in there. Okay, 6 months later, you load it, everything fails. That's worse, you wasted 1 year of the guy's life. And then you tortured him 2 times.
3 times actually, because if you put the implants and put cover screw, you still need to uncover and put the healing button or your multi-unit. So you tortured him 3 times for 1 year, and nothing happened. In fact, you have more infection and fibrous tissue that you need to remove from your sinuses and foreign material that you need to take out. So I would say, if you think zygomatic is very, very maximally invasive, I would say sinus lift is maximally disruptive. Minimally invasive, maybe. Maximally disruptive. You disrupt the patient's life for like 1 year, and then after one, it's like you go for a girl, you hit on the girl, you take her out on dates, and then 1 year later she's like, I'm not gonna marry you, we're done. You get what I mean? So it's a commitment on them financially, it's a commitment on them psychologically, it's a commitment on you, your chair time, everything. To me, the whole thing is just, you just lose money in it. So sinus lift is the last option when it's fully edentulous. Last option. Again, whenever you're looking at any case, unnecessary action and tools, Ostel, densifying the surgical guide, it's all unnecessary tools. To me, it's extra tools, and if the tools don't work, you still have to go back to your base. If you build up from having your basic surgical skills or your basic prosthetic understanding, then you add the tools on, then it's okay. Then you do the guide later, whatever. But if you start with the guide, you start with densifying, you start just using Ostel, you don't have a base for you to fall back on when these things fail you. Again, look at the case. Combination syndrome. Very, very bilateral. K-Wood, Hellwood, probably 4 or 5. And just horrible lower teeth. In the original days, we do block bone grafts, lateral windows, and in some cases zygomatics for the case like this. I want to introduce something called the palatal approach. Have you heard of it? You heard of palatal approach? With the palatal approach, you can circumvent doing sinus lifts, circumvent doing zygomatics for a large population of your cases. Like if you take away anything today, take away the palatal approach. That's the only thing I want. It's a lifesaver. This is actually the first case I did the palatal approach. I presented this at the Bangkok Implant Symposium for one of their presentations on oral papers, paper presentations. I wrote the paper about it 7 years ago. And at that time, I'm like, that's crazy. You got so many threads exposed. I'm like, people doing it overseas, and this has been around for 20 years. So in this case, we ended up doing palatal approach, transsinus, and just septal implants. So you see that septum in the maxillary sinus. Try to aim to get that, because that's the one with some cortical bone there for immediate loading. And the lower, we did standard all on fours, and I tried a stupid experiment in the anteriors because there were papers out at that time. They said, hey, you don't need multi-unit on some of your implants. So we went direct to the implant on the mandible, and you can see that later in the prostheses. Okay, this is the paper that started the palatal approach. Torsten published this in 1999. This is a good 27 years ago. Torsten published the article describes a surgical technique for implant treatment severely disrupted edentulous patients. 15 patients treated with osseointegrated implants. All patients were initially considered for bone grafts because they had lack of bone. And by fenestrating a maxillary sinus and uncovering the nasal floor, the maxillary bone could be visualized and used. And then they angulated the implants and permitted the implants to be placed with high torque. If you guys can get this paper through Sci-Hub or something. So unless you're like faculty members in like university, try to read the paper. He actually placed the parallel approach, but he didn't immediately load. He placed them and he put cover screws and uncovered after 3 months and then loaded it. But the idea was 2 to 5 threads exposed parallelly, no grafts. Implants wider than the bone itself. Preservation of buccal cortical bone. So the buccal cortical bone and your crest, your crest becomes the buccal bone. The crest becomes the buccal side. Instead of drilling to the crestal bone, you're drilling perpendicular 5 mm below the posterior section of the crest. So the crest becomes the buccal bone. I'll explain it to you. And again, you cannot use a guide for this because you need to swing that burr, especially the first spade drill, the pilot drill, and the 2.0. The spade and the 2.0, you'd have to aim it and then redirect it. Aim it and then redirect it. So you cannot use a guide for this. Okay, here you can tell this is the bone that's left. Very thin. And we're able to put the implants palatally. This is the nasopalatine canal. We stripped it open and then we put the implants palatally. Again, you'd think, oh my God, that is going to go so palatal that I cannot restore properly. I'm going to have like too palatal of an emergence. Again, in this case, it's okay. I use a straight multi-unit and it still comes out in the cingulum. But in cases, a lot of cases, you need an angle multi-unit to swing the emergence forward. You need 17 degrees, 30 degrees, put the emergence forward. But this case turned out okay. Again, you can see from the CBCTs here how we do this. This is the nasal floor. And you see, we left all the buccal bone. Look how thin that buccal bone is. And then we got about 50% of this inside bone. And this is taken 5 years after the initial surgery. And you can see that. Again, the other side. I did this on the anteriors. So the palatal approach works. There's no destruction of your leftover bone. The buccal side maintained. See that? But for you to drill straight in, you can think about it, this is just the cortical. You'd have to drill at an angle and then swing it downwards. So you've done anterior implants before, where you have to go like this and come in. Same thing here is the other way in reverse. You come 5 millimeters below the crest, go perpendicular, and then swing it forward. So you need to swing that burr, especially the first 2 drills, spade and 2.0, maybe even the 2.5. And you can get really beautiful results with this. Again, this is the transsinus. We went through the sinus and engaged the portion towards the other side of the nasal floor and engage the bone here. And in cases that have very, very hazy sinuses, we call it sinusitis, asymptomatic sinusitis, or they could be having sinus polyps or sinus mucosal cyst. In those cases, I'd create a buccal window, a lateral window, lift it, and then go for the transsinus. The key is you need 4 mm of crestal bone to do transsinus. If you have 2 mm, there are guys who do 2 mm too. I think it's just a risk of oral enteral fistulas in the future. In the future. Again, back in the day, before Freedom Air Scanner, before we had photogrammetry, we had to pick up all the implants with cylinders. You call it titanium cylinders, you call it MUA abutments, not MUA abutments, MUA copings. You'd have to attach them, and then you'd have to drill holes in your denture and pick it up. Now I come from surgery. I come from oral surgery and maxillofacial. I started off doing this just before COVID. I came back from a cleft lip fellowship in India. And then it was like around COVID time, I'm like, oh man, how are we gonna make money? And then we get so many cases of all-on-fours coming in. Patients have been rejected by other surgeons, by other dentists. So I thought, I'm gonna do that for you. And then I started like biting off more than I could chew. I told them, I'll get your teeth in one day, the same day. And they're like, how? Okay. Then I went on YouTube, because I come from surgical background, I'm not a prosthodontist. And then I picked up something called denture conversion. And I looked at all the YouTube videos. I spent more than 2 days just looking at different YouTube videos on denture conversions. I tried denture conversions on like the models, and I think this is easy. This is so easy. Let me do it. It's not easy, especially when you've done the surgery, and then you got to do the conversions straight away after. So I used to tell I brought in a denturist. He's like a guy that does dentures. I told him this: when you finish your surgery, tell yourself this: you're only 50% done. You're not even finished. You're only 50% done. And that taught me a lot of discipline to stay through to the end. We converted the dentures, and then we gave him a malo bridge in the end. Very happy man. I still see him this day. So we gave a malo bridge. If you see him today, after 7 years, some of his teeth have chipped off. And I tell him, hey, I want to redo it. I don't feel good. I want to redo it for you. He's like, no, I like it. It looks natural now. Looks like my real teeth. I'm like, man, okay. Yet here, my stupid idea was, I read a research paper that showed that you don't need multi-units, and you can go direct on like the 2 anterior mandible implants. They did a paper about it. The reason I did this is, at that time I was working for a dental clinic chain in Malaysia, and we had to order implants in piece by piece. So everything had no discount. So one multi-unit abutment cost me like $300, 300 USD. So I was like, hey, can I skip 2 multi-unit abutments? Can I save some money on this? And hey, he's still good today. So, but it was horrible trying to restore it. I had to like splint the copings in the mouth. I'll talk to you about like the difference between digital photogrammetry, scan ladders, intraoral verification jigs, and then verification jigs later towards the end. And have you splinted impression copings together before? And then you've done verification jigs before? Not fun to do, man. Horrible. Again, this is important. See the palatal approach. Look at the tissue. Look, if you were to look at this, you'd think he has like 12 mm of buccal palatal bone. But actually he has 1 mm buccal bone. Because the palatal tissues are keratinized. And why do we not graft them? Because the palatal tissues get hemidesmosomal connections to your implants, to the soft tissue, which is the keratinized tissue here. And they connect there. It's sort of like a reverse zygomatic implant. Back in the day, zygomatics were just all threaded all the way. So it's like a reverse of that idea, palatally. And you can see the tissues, very beautiful tissues. Almost like there's bone here, but there's no bone. Okay, this is a case where you see terminal dentition. To me, terminal. Again, you see him here. It looks horrible. There's no way for him to look good with the current teeth. Like, I cannot think of a way for him to look good. And he had Straumann implants placed here on grafted bone. Again, to me, terminal. To you, maybe not. To me, if I have teeth like this, or my dad has teeth like this, I will extract everything. I want to go to my daughter's wedding with more beautiful teeth than this in one day. Again, here, teeth were removed. The Straumanns were taken out because they were on grafted bone. I don't trust grafted bone. I reverse torqued and I took them out 25 newtons. Try reverse torquing your own implants. You don't need osteo. After you finish, 4 months the patient comes back, you reverse torque it. If it lasts more than 45, you're good. If it comes up together, oh my gosh. I don't reverse torque, I was just joking. But back in the day, they do that. Back in Brandon Mark's day, every implant, after 6 months, reverse torque test, 35 newtons. If 35, it comes up, fail. Back in the day, 1982 to 1995, all his cases, reverse torque test. In fact, when you do